evening and thank you everyone for joining us today. I, Amit Saxena, along with my colleague, Dr. Deepika Chabra from Medical Services and Mr. Rakesh Kumar, Zonal Sales Manager, Jagsonpal Pharmaceuticals, are pleased to welcome you all to this AOGD Delhi PG Forum for presentations by postgraduates of ABVIMS and RML Hospital, New Delhi, with Jagsonpal Pharma Ltd as academic partner. We thank you for this opportunity to connect with you through this webinars and are proud to present DIVATRONE 100 mg tablet, fully indigenized micronized dydrogesterone. We also present injection Maintane 500 and 250 mg hydroxyprogesterone helps maintain pregnancy till term, and LycoRed soft gel. We would like to express our gratitude and warm and hearty welcome to esteemed experts and speakers. We kindly request you to post your questions, explanations, suggestions via text in Q&A box or chat box. This webinar is streaming live on Facebook and the link is already shared in this for circulations. Now I request Chairperson ma'am to please kindly proceed.
Welcome to the Delhi PG Forum on today's class. It's going to be on postmenopausal bleeding, how to go about it, and finally how to go to the diagnosis of carcinoma endometrium. For this, we have Dr. Asmita Rathod. Can I have her? She is President AOGD. She is also Director Professor and HOD Obst and Gynaec of Maulana Azad Medical College, New Delhi. And she is area of interest has maternal fetal medicine and vaginal surgery. And she's about to have a conference, AOGD annual conference on 5th month on 12th and 13th. So I would like all of us to join that conference also. And our moderators for and chairperson and moderator for today's class are Dr. Ashok Kumar. He's Director, Professor and Head, Department of Obst and Gynaec, Hari Vajpayee Institute of Medical Sciences and Dr. Ramano Loya Hospital, New Delhi. He's also ICOG Secretary General and editorial board member of Indian Journal of Medical Research, Archives of Gynaec and Obst. Next chairperson is Dr. Rupinder Sekhon. She is Senior Consultant and Chief Gynaec Oncology, Rajiv Gandhi Cancer Institute and Research Center, Delhi, India. She is also Program Director of DNB Super Specialty Gynaec Oncology and Associate Editor of Indian Journal of Gynaec Oncology. And she is Secretary General of Association of Gynecological Oncologists of India. And they are going to chair and of course moderate, and the immediate moderator are Dr. Neha Pruthi. She is Assistant Professor in ABVIMS and RML Hospital. She has received Indumati Javeri Prize for Best Paper Presentation in AIOCG, Young Turk Award, Foxy Traveling Fellowships, Best Oral Presentation, competition papers, and her special interests are infertility and high-risk pregnancy. She's got many publications. The other moderator is Dr. Rashmi. She is Associate Professor in UCMS and GTB Hospital, Delhi. She was Organizing Secretary of CME and GTN. That was recently done in 2 months back. And she was also organizing masterclass, Secretary of Masterclass in CA Endometrium 2021. Got a lot of experience from gynecology. She's a passionate teacher with many publications and chapters in book. And she is also editor for South Asian edition of Barracks and Ovets Gynecology. So over to you.
And we welcome Ayushi and Aparajita. Actually, they have worked hard to prepare the case, and I think they have read a lot also.
Good evening, respected seniors. We'll be presenting a case on postmenopausal bleeding. My patient, Mrs. X, wife of Mr. Y, 62-year-old female, Hindu, resident of Trilokpuri, Delhi, homemaker. She's para 2, living 2, married for 40 years, postmenopausal since the last 8 years. Patient presented with the chief complaint of spotting per vaginum since 2 months. Patient was apparently well 2 months back when she developed spotting per vagina. She has had 3 episodes in the past 2 months, each lasting for 1 day. The last episode was 2 days back. It was spontaneous in onset, fresh red in color and resolved on its own. It was staining only her undergarments and not requiring any pads. It was not associated with abdominal pain or abdominal lump. There is no history of preceding genital trauma or coitus, not associated with any foul-smelling discharge, no history of any drug intake, no history of any vaginal pessary use, no history of any mass felt protruding per vaginum, no history of ulcer in the perineal region or any history of surgery.
Ayushi, can you now just tell me why have you taken all these histories?
Yes, ma'am. Ma'am, any genital trauma or any history of coitus could also result in bleeding. Then, ma'am, foul-smelling discharge, I have taken the history because to rule out cervical carcinoma, ma'am.
Any other cause of foul-smelling discharge?
Ma'am, due to cervical stenosis, there could be a pyometra, could also be there. And there could be foul-smelling discharge because of that.
Yes, it could also be because of an infected polyp.
Infected polyp, yes, ma'am.
Okay.
Then, ma'am, then the history of drug intake. Ma'am, I asked if the patient was using any HRT, any hormonal therapy was being taken by the patient, any history of topical application of any hormone or any anticoagulant therapy that the patient was taking. Then, ma'am, any history of mass felt protruding per vaginum.
Wait, just a second. Drug intake, any other drug which in particular you would like to ask?
Ma'am, history of tamoxifen intake also. That
yes,
could also
and also some herbal drugs, Ayurvedic drugs, they do contain hormones. So these females have habits of going to Ayurvedic doctors and taking some drugs. So you have to specifically ask for that also. Okay.
Yes, ma'am. Yes, ma'am. Ma'am, then I asked any history of mass felt protruding per vaginum to rule out any polyp or any other pathology, ma'am.
And what other pathology you think could have caused bleeding?
Ma'am, an ulcer. If there was an ulcer.
In a prolapse. Basically, postmenopausal females usually have prolapse, and due to friction, there are decubitus ulcers, which can present as spotting also.
Yes, ma'am. Okay. Yes, ma'am.
Continue.
And then there was no history of hematuria, burning, micturition, dysuria, increased frequency of micturition or urgency. No history of bleeding per rectum. No history of altered bowel habits, constipation, diarrhea, painful defecation, dark colored or blood-stained stools. No history of loss of appetite, early satiety, cough or hemoptysis or significant weight loss.
So one by one, do explain why you have taken these histories?
Yes, ma'am. Ma'am, I've taken history of hematuria, burning, micturition to rule out UTI. Ma'am, then I've taken the history of bleeding per rectum to rule out.
Also, Ayushi, there can be atrophic urethritis also, which can also cause bleeding.
Yes, ma'am. Yes, ma'am. And then the history of bleeding per rectum, I've taken the history to rule out any hemorrhoid or fissure, which could be mixed up with the vaginal bleeding. Any rectal bleeding could be mixed up with the vaginal bleeding. And ma'am, I've taken history of loss of appetite, cough, hemoptysis to rule out advanced stage of carcinoma, ma'am.
Basically, metastasis is an advanced stage of the disease, right?
Yes, ma'am.
Continue.
In the obstetric history, the patient is married for 40 years. She's para 2, living 2. Both full-term vaginal deliveries at home. Her last childbirth was 18 years ago. There was no history of any preceding infertility. The patient breastfed her children for 2 years. She was using barrier contraceptive. There is no history of any other contraceptive intake. No history of high-risk sexual behavior in the patient or the husband.
Okay, so now can you tell me what is the importance of obstetric history in your case?
Ma'am, in the obstetric history, ma'am, first, nulliparity is a risk factor for endometrial carcinoma. Apart from that,
ma'am, multiparity is a risk factor for?
C cervix, ma'am.
Right.
Yes. Okay. And ma'am, the breastfeeding has a protective role in endometrial carcinoma. So we asked for the history for the amount that the patient breastfed. Ma'am, apart from that, ma'am, we asked for
history of infertility. You have specifically mentioned infertility.
Ma'am, if the patient was having infertility, she could have had anovulatory cycles, ma'am.
So anovulatory cycles, how can
they increase? Ma'am, unopposed estrogen is a risk factor for endometrial carcinoma.
So yes, in patients of PCOS, PCOD, basically they have anovulatory cycles, which causes increased risk of endometrial hyperplasia and followed later on increased risk of endometrial cancers. So why have you taken this history of high-risk sexual behavior for the patient?
Ma'am, for HPV, ma'am, postmenopausal bleeding could also be due to cervical cancer, and ma'am, a precursor of that is HPV infection, ma'am.
So basically, when you have a patient with postmenopausal bleeding coming to you, we have to have a set of things in our mind to make a diagnosis. So to one by our history, we are going to rule out everything. So all these histories of high-risk sexual behavior is going to point that it is not towards CS cervix. So we are asking history to rule out CS cervix.
Yes.
Okay, continue.
And also, just a point, Ayushi, that contraceptive history you should not include in the obstetrical history. You should have it separately. Right?
Separate history, right?
Yeah. Okay, ma'am. Okay, ma'am. Then, ma'am, in the menstrual history, the patient attained menarche at 13 years of age. Her age at menopause was 54 years. She's been postmenopausal since the last 8 years. Her previous cycles were regular, and her perimenopausal period was uneventful.
So basically, I would like to know, why are we worried about her menarche? Why are we worried about her menopause? Do you think is there any importance?
Yes, ma'am. Ma'am, early menarche and late menopause are both risk factors for endometrial carcinoma.
Why?
Ma'am, they increase the estrogen exposure, ma'am. The duration of estrogen exposure is increased.
So the more the time the estrogen exposure is there, more are the chances of endometrial hyperplasia later on leading on to endometrial cancers.
Cancer, yes, ma'am.
Okay.
And ma'am, also the age at menopause. Her age at menopause is a little late than the average Indian population, ma'am.
What is the average age?
Ma'am, 47 years is the age, ma'am, average Indian population.
Yes, so we say it is between 45 to 50 years. Usually they attain menopause. And if a female keeps on menstruating even after 50 years, so at what time will you start investigating her, or we can leave her till she keeps on menstruating?
Ma'am, for 55 years is the cutoff, ma'am. Beyond 55 years, if the patient is still menstruating, then we need to evaluate her.
So we become cautious at 52 years of age. If she is still having heavy bleeding after 52, we start evaluating her.
Yes, ma'am.
Okay, continue.
In the past history, patient is a known case of hypertension since the last 4 years. She's on telmisartan 40 milligram once a day. The patient is compliant and her blood pressure records are well controlled. There is no history of any other chronic medical illness or cancer. No history of any surgical intervention.
Okay, continue.
In the personal history, patient is a homemaker, vegetarian, non-smoker. There is no history of any drug abuse or intake. No history of change in bowel or bladder habits. She has a normal sleep pattern. There is no history of any allergy or any history of cervical cancer screening in the past. The patient belongs to the lower middle socioeconomic class by the modified Kuppuswamy scale. In the family history, there is no history of any chronic medical disorder in the family. There is no history of cancer of breast, ovary, uterus, intestine, or stomach in the family.
Okay, now just a second. Now I want to know that why you have been particularly asking for all these cancers in the family.
Yes, ma'am. Ma'am, to see an association, ma'am, because endometrial cancer, for example, ma'am, it has around up to 10% cases of endometrial carcinoma are hereditary. There are hereditary syndromes
5%.
which
5 to 10%. There are
yes,
familial.
Not 10%. Yes. It is less. It is around 3 to 5%.
3 to 5%. Yeah.
Okay, ma'am. Okay, ma'am. In this, there are familial syndromes, ma'am, which increase the risk of endometrial carcinoma.
Can you name them?
Yes, ma'am. The syndromes are like, ma'am, the Lynch 2 syndrome, which was earlier known as HNPCC. Ma'am, this increases the risk.
Just tell the full form.
Hereditary non-polyposis colorectal cancer.
Right.
Ma'am, this increases the risk of endometrial cancer by 60%. And it occurs, endometrial carcinoma in this syndrome occurs 10 years younger than the average age of presentation.
So basically, in Lynch syndrome, what other cancers which the patient is going to have? She's going to have endometrial cancer along with?
Ovarian, colorectal, stomach, ureter, ma'am, these can be involved.
Most importantly, colorectal cancers are more common in
50 to 60% of them.
The endometrial cancers. And is there any association of breast cancer with
Yes.
endometrial cancer?
Yes, ma'am, there is association, ma'am. It is seen that there is increased risk of endometrial cancer in patients with family history of breast cancer. The BRCA1 association, ma'am, there is association between BRCA1 and endometrial carcinoma. And also, ma'am, if the patient is having breast cancer and if she's taking tamoxifen, that increases the risk by 2 to 4 times, ma'am.
Right. So is there any other syndrome?
Yes, ma'am, there is Cowden syndrome, in which there is a mutation in the P10 gene. And ma'am, it is associated with thyroid, stomach, and colorectal cancer. It encompasses this these
and skin malignancies also.
Skin malignancies also. Yes, ma'am.
When you take family history, you can write, or at least you should have written no other cancers also. Okay.
Yeah.
Because specifically you have not written about the thyroid cancer. So generally you inquire about any other cancer.
Thyroid cancers are usually common in the Cowden syndrome also.
Yes,
so we have to be knowing about these associations of different cancers and the risk which has increased. Okay, now
Ayushi, it is not the 60% increase in the risk. The risk can means the
there's risk. Yes, ma'am. Total risk.
Risk of having lifetime risk of having endometrial cancer can be up to 50-60%.
Yes, ma'am. Yes, ma'am.
Okay.
In the dietary history, the patient consumes a mixed diet with total calorie intake of 2,400 kilocalories and protein intake is 50 grams. In the
wait, we'll stop at history. So yes, can you just tell me what is your diagnosis according to on the basis of your history before we proceed to the examination?
Yes, ma'am. Ma'am, my patient, 62-year-old para-2 living to postmenopausal woman since 8 years with postmenopausal bleeding. Ma'am, I'd like to keep my first differential as atrophic or senile endometritis, which is one of the most common causes of endometrial carcinoma. And then I'd like to keep my second differential as endometrial polyp. Then I'd like to keep my differential as endometrial hyperplasia and then endometrial carcinoma, ma'am.
Then why have you taken endometrial polyp as your first or the second diagnosis?
Yeah.
Ma'am, the patient was having spotting, ma'am, on and off over 3 months, ma'am, and the bleeding was not that severe.
So what are the most common cancers which we expect in postmenopausal females?
Ma'am, cervical and endometrial. Cervical
so how
cancer.
much percentage is the cervical and endometrial cancer?
Ma'am, cervical cancer is seen in around 15% cases of postmenopausal bleeding. And ma'am, there is a range of 2 to 14% for endometrial cancer with an average of 10%, ma'am.
So basically around 25% of all the postmenopausal bleeding females, they usually present with, they can have malignancies. That's why we need to be, very cautious about that. And atrophic endometritis, atrophic vaginitis are the most important causes. And they usually, the females present with this kind of history only. There is very little spotting and it usually stops on its own. They do not require any medication. And we need to understand that polyp will also be is also one of the differential diagnoses we need to keep in mind. So now we'll proceed with the examination, which will further guide us towards the diagnosis.
Yes, ma'am.
Okay.
On examination, the patient is conscious oriented to time, place, and person. Her height is 156 centimeters and her weight is 80 kilograms, making her BMI 35 kg per meter square, which makes her obese, and the obesity class is 1. Thyroid was not found in large. There was no significant generalized lymphadenopathy. There was no pallor, icterus, clubbing, or cyanosis or pedal edema in the patient. Her temperature was 98.4 degrees Fahrenheit. Her blood pressure was measured in the right arm in sitting position and it was found to be 130 by 82 millimeters of mercury. Her pulse rate was 82 beats per minute and it was measured in the right radial artery, which was good in volume, regular, with no radial or radiofemoral delay. Her respiratory rate was found to be 18 per minute for upper abdominal.
Okay, now you need to tell me what all lymph nodes will you like to palpate in such a patient?
Ma'am, we will first check for the generalized lymphadenopathy in this patient. We would like to start with the cervical lymph nodes, the clavicular lymph nodes, supraclavicular lymph nodes, and we would also like to check for axillary lymph nodes and inguinal lymph nodes in this patient.
Right. So we have to go and evaluate all the lymph nodes. Okay, continue.
Ma'am, the breast examination was done and it was found to be normal. No mass was palpable and no nodes were palpable in breast and axilla examination. On cardiovascular system examination, S1 and S2 were heard and no added murmurs were heard. On respiratory system examination, bilateral air entry was found to be equal and no added sounds were heard.
Okay, continue.
On abdominal inspection, after ensuring that the patient had passed urine and after asking the patient to lie supine with adequate exposure, on inspection, the abdomen was found to be uniform and obesity was present. Umbilicus was central and inverted. All 4 quadrants moved equally with respiration. There were no visible veins, pulsations, scars, sinuses, fistulae, or peristalsis. Horner orifices were found free on coughing. On palpation, the abdomen was soft, non-tender. No mass was palpable and no organomegaly or guarding or rigidity was elicited in the patient. On percussion, no shifting dullness or fluid thread were present, suggestive of no ascites. And on auscultation, no normal bowel sounds were heard in the abdomen.
Okay, so as you have mentioned that there is no mass palpable, if there would have been any mass which was palpable, basically abdominopelvic mass, what would have you kept in your mind?
Now, if there was an abdominopelvic mass in on examination, our differentials would change, and not just the uterine malignancy. We would also keep in mind ovarian malignancies. We would also keep in mind any other pelvic pathologies, and we would also keep in mind cervical malignancies, which could be advanced. And
basically more common. Yeah. See, it can be enlarged uterus, but with what?
Enlarged uterus, we could have uterine fibroids.
Yes.
In the patient.
And also,
it can be pyometra,
hematometra, the cervical stenosis.
Postmenopausal, think of those also.
Postmenopausal female coming with spotting, it could be CSV. We are yet to examine to her PSPV. So
yes,
we can think if we are doing a per abdomen examination, it could be a pyometra which you are feeling as a central mass in the abdomen. Or there could be any ovarian mass.
Yes, ma'am.
Right?
Yes, yes,
so what ovarian masses can increase endometrial thickness and cause bleeding?
Ma'am, estrogen secreting tumors such as granulosa cell tumors can present the same way as well.
So that is what you need to keep in mind, is granulosa cell tumors, estrogen secreting tumors, when we are thinking of taking this history. That is why it is important. Okay, now continue.
On local examination, the external genitalia were found to be normal. There were no evidence of any ulcer, mass, pigmentation over the vulva. On per speculum examination, the cervix was found flush with the vagina. So cervix and vagina were found healthy. Vaginal mucosa was pale with vaginal rugosities were present, but they were decreased. No lesion or abnormal discharge was seen coming from the cervix, and no bleeding was seen coming from the cervix or vagina.
Okay.
On bimanual per vaginal examination, the cervix was smooth and firm in consistency. No lesion or growth were palpable. The uterus was anteverted. It was normal in size and shape. It was firm in consistency, non-tender and mobile. Bilateral fornices were felt free and non-tender.
Okay. So now after, okay, do a rectal examination.
I did a rectal examination for this patient as well. The anal opening was found normal looking. The rectal mucosa on examination was found to be smooth and free. On PVR examination, no nodularity was felt, no thickening was felt in the pouch of Douglas or the parametrium.
Okay. So now you have done your history, you have done your examination. So on the basis of your history and examination, just summarize your case and tell me your provisional diagnosis.
Ma'am, as per my history and examination, the patient is a 62-year-old female who's postmenopausal, para 2 living 2, with postmenopausal bleeding, likely due to endometrial carcinoma, with obesity class 1, with hypertension.
So now tell me why you have now shifted your diagnosis from atrophic endometritis and then polyp. Now you have shifted to endometrial CA.
Yeah.
So what are your points in favor for endometrial CA and why you have ruled out atrophic endometritis and vaginitis?
Ma'am, I have changed my diagnosis. My first differential has now become endometrial carcinoma because of the age of the presentation of the patient, that is 62-year-old.
Yeah.
She attained a late menopause at 52 years of age. She is also.
But that all was, just a minute, yeah, that all was there in the history. So when we asked you about the about your diagnosis,
and there were certain points in examination that guided us further towards our diagnosis. That is that the patient was found to be obese. She had class 1 obesity, and there were no lesions seen on the per speculum and per vaginal examination, which ruled out cervical pathology and pointed more towards an endometrial pathology in this.
And your besides that, your atrophic endometritis and atrophic vaginitis you have to see. So you said that rugosities are still present.
Still present. So
yeah.
atrophic pathology.
So that means there is some amount of estrogen is present. So where do you think this estrogen is coming from in this postmenopausal female?
Ma'am, because the patient is obese, there is peripheral conversion of the androgens to estrogen in this patient. So it could be causing an increased amount of estrogen in this patient, despite her menopausal status.
Okay. So I would just like to know that endometrial CA, you are saying that this is endometrial CA. As compared to CA cervix, which is more common?
CA cervix is more common as compared
to cervix.
in the breast malignancies.
But now endometrial CA incidence is now increasing. Why do you think that this endometrial carcinoma is increasing nowadays?
Ma'am, endometrial carcinoma is increasing in patients because of change in the lifestyle pattern of people, and there is increase in lifestyle diseases like diabetes, hypertension, and obesity, which are commonly present to us as corpus cancer syndrome in endometrial carcinoma patients.
So basically, now we are actually adapting to the Western lifestyle. We are eating more of junk food. There is less of exercise. So obesity, all these are ultimately leading to increase in estrogen, which are basically leading to high risk of endometrial CA.
Yes. Obesity, actually, obesity is a very, when there is increase in the BMI, you know, when with increase in the BMI, there is a lot of increase, means the risk of CA endometrium increases a lot. So with every increase in the BMI, it is like 5% increase in the, or 50% increase in the risk of C endometrium. So obesity as such is a very high risk factor for C endometrium. But otherwise also nowadays they say that in the Black populations, incidence of C endometrium is increasing. They don't know exactly what is the cause. Okay, so again, what are your differential diagnoses? Still, it is not like you are very sure that it is endometrial cancer. Now, after examination, yeah, tell me.
I would still like to have my differential diagnosis as endometrial hyperplasia, endometrial polyp, and senile endometritis or vaginitis. Okay. I would still like to keep them, and I would like to evaluate the patient further and come to a conclusive diagnosis then.
Okay. From the history, like you have discussed about the reasons, the factors which increase the risk of C endometrium, are there any factors which are protective?
Yes, ma'am.
What are those factors?
Yes, ma'am. The protective risk factors are, ma'am, the history of any oral contraceptive pill intake, ma'am. There are broadly, ma'am, 2 studies were done which showed that continuous use for 5 years, ma'am. There was a cash study which was done in which a continuous use for 12 years was found to be 50% to 60% protective for endometrial carcinoma.
Risk reduction in the,
yes, ma'am. There was risk reduction, ma'am. Apart from that, ma'am, breastfeeding is also protective. Multiparity is protective, ma'am. Physical exercise and consumption of phytoestrogens and diet rich in fruits and fiber.
These are basically the overall you are telling about the protective factors. So yes, ma'am's question was, what are the protective factors in your patient, in your case?
Ma'am, the multiparity of the patient, she's para 2, living 2, ma'am.
And she was breastfeeding.
She was breastfeeding, yes, breastfeeding.
Yes.
Okay, fine. Fine. So how will you further now investigate this patient?
Ma'am, for further investigating the patient, I would like to do routine pap cytology for this patient and ask, and simultaneously I would like to get a USG done for the patient, and preferably I would like to get the USG as a transvaginal scan done for the patient to look for the size of the uterus, to look for the endometrial thickening, to look whether there is any lesion in the endometrial cavity, to check for the adnexa, and to look at the cervix and the endometrial canal also.
So most important, you have to look at the endometrial myometrial junction also.
Junction also. Any myometrial lesion.
So whether
you have to look for everything. And why you said you will go for transvaginal scan specifically? Why not TS?
Ma'am, there are 2 points because of which I said I would like to go in for a transvaginal scan, because the patient is obese and she has the uterus on examination was found to be normal size. So I would like to go in for a transvaginal scan, and it would better pick up endometrial diseases.
In which cases will you like to go for transabdominal scan? Followed by
if the size of the uterus is large, then I would like to go in for a
large means how much large? It can be 8 weeks, it can be 12 weeks, it can be 10 weeks.
If it becomes 12 to 14 weeks in size, that is, it comes out of the pelvis, becomes a large, not a pelvic organ.
Then what happens? Then why can't you do transvaginal scan in that situation?
Ma'am,
is a reason.
Ma'am, because I would like to in a transabdominal scan in such a case will be better able to pick up the endometrial pathology as compared to a transvaginal scan.
Why it is like that? Because what is the basic difference in the scanning probes in the transvaginal scan and the transabdominal scan? What is the difference between them? which has higher which has higher frequency. Transvaginal scan has higher frequency.
Higher frequency than the
Transvaginal scan has a
transabdominal
higher
scan.
frequency as compared to transabdominal.
So it has more, it has less
Sensitive.
penetration, but it has a better resolution. Okay, so as it has less penetration, so if the size becomes large, then it will not be able to detect. If you do transvaginal in a large uterus,
Yes.
you will not be able to see the whole of the uterus. Okay, and otherwise also, if you are palpating any abdominal mass or the large uterus is there, first you have to always do transabdominal scan. Then you go on to transvaginal scan. Okay.
Yes, ma'am.
Yes.
Right. So what were the findings in your case?
Ma'am, in our case, the ultrasound pelvis transvaginal scan was done and the uterus was found normal in size. The endometrial thickening was found to be increased. It was 16.5 mm and it was heterogeneously hyperechoic, and nexus were also examined, which was found to be normal. There was no mass.
Okay. So what does it suggest you? What do you think is the, now you're, again, you keep on zeroing down on your differentials, no?
Now I have only 2 differentials left for this patient. Either she is endometrial hyperplasia or she is endometrial carcinoma because of the increased endometrial thickness. It could also be an endometrial polyp, but my diagnosis towards endometrial polyp is less because this is seeming more like a global pathology and less like a local pathology. A small.
Suppose you have a doubt about it being the polyp. So can you do anything else on TVS?
Yes, ma'am. I can aid my diagnosis by using a saline sonography, saline infusion sonography, which will help us delineate uterine polyps better. And we can also use color Doppler in this case, because if there is any feeding vessel to a polyp, it will be picked up better with the Doppler in the USG. These 2 things can help us aid with that.
Anything else that should have been mentioned on transvaginal scan, which is not mentioned here? Like we discussed what all needs to be seen on ultrasound.
Endomyometrial junction. Endomyometrial junction.
So that also needs to be seen. So like you are saying, it is very thick. So what is the normal endometrial thickness?
I'm in a postmenopausal female. The normal endometrial thickness is less than equal to 4 mm. And if it increases more than 4 mm and the patient has any complaints of postmenopausal bleeding, then we would like to evaluate the patient.
Any other condition which increases the endometrial thickness and there may not be any malignancy?
Ma'am, endometrial hyperplasia.
Okay, means any other history which means the factor in the history.
Ma'am, history of tamoxifen intake can increase the endometrial thickness.
Tamoxifen use also increases the endometrial thickness, and if she is not having any postmenopausal bleeding, there is no need for endometrial sampling in those situations.
Yes, ma'am.
Yes, ma'am.
Okay. So what will you further like to do now?
Ma'am, I would also like to go in for endometrial sampling for this patient because of her thickened endometrium lining. And there are various methods of endometrial sampling which we can use. But in this patient, because it is a global pathology, I would like to go in for a office endometrial aspiration biopsy for the patient.
So what are different methods? Yeah, just tell us what are the different methods of taking endometrial biopsy and why you said you will go for the office aspiration site biopsy.
Ma'am, office biopsy can be performed for the patient, and the different methods that we can use are using a Carbon's cannula, which we commonly use in our OPDs. We can also use Pippel's aspirator and Vabra's aspirator. We can also do a hysteroscopic guided biopsy for the patient. We can also perform a DNC, which is considered gold standard.
Why don't you want to go for DNC now, and why you want to go for the aspiration biopsy?
Ma'am, I would like to go in for office biopsy for this patient because it is a global pathology, and I would not like to go in for a DNC because it requires anesthesia and an OT setup for the patient, and it is more invasive, and office biopsy can be performed as an OPD procedure.
Okay, so what are the different devices which can be used to take
Ma'am, Pippel's aspirator, Vabra's aspirator, and Carbon's cannula can be used. Pippel's, out of the 3, is considered the best. It has 99.6% sensitivity for endometrial diseases. And we, however, commonly used Carbon's cannula in our OPDs.
Okay. So actually, people, you can always go for the people because it does not need any dilatation of the cervix.
Yes,
so there is no need of any anesthesia, or it is sort of a painless procedure you can do in the OPD settings. But if there is any doubt, you always go for the hysteroscopy.
Yes.
Okay. So what are the conditions in which you will directly like to go for hysteroscopy and directed biopsy?
Yes, ma'am. Ma'am, if the patient is coming with recurrent postmenopausal bleeding, but on ultrasound, her endometrial thickness is found to be less than 4 mm, then I might offer her a hysteroscopic guided biopsy. Also, if there is a localized lesion or a localized thickening in the endometrium, then also we'd like to do a hysteroscopy. If on outpatient or office biopsy, if our biopsy comes out to be inadequate for opinion, then I would like to confirm it with hysteroscopic guided procedures.
Also, ma'am, if there is if the report gives endometrial hyperplasia, ma'am, then also we'd like to go for hysteroscopic guided biopsy.
Any other reason? Sometimes you are not able to perform the office biopsy because of cervical stenosis. Then also
yes,
you have
anesthesia is required.
Take that patient up. And other thing is that suppose the histopathology comes out to be some benign, like atrophic endometritis is there,
the patient has recurrent
hyperplasia is there, but she is having recurrent postmenopausal bleeding. Then you have to go for hysteroscopy, and then you have to see the endometrial cavity and then take a biopsy. Okay, so hysteroscopy with biopsy is still and many people like to go for directly also hysteroscopy and
yes, ma'am.
Okay. Have you heard of a device called tau brush?
Yes, ma'am.
So can you just tell what exactly it is and can it be used or not?
Ma'am, tau brush can be used, but ma'am, it is not readily available, ma'am. It has two ends, ma'am. It has a stick along with the brush on the top, ma'am, it has a depth of, it can be used till a depth of 1.5 to 2 millimeters. Tissue can be collected, ma'am, with it. And 360-degree rotation is done, ma'am, in the endometrial cavity using a tau brush. And it has good sensitivity and specificity, ma'am.
So yeah, it
How
is
much is the sensitivity compared to people?
Ma'am, it is around 90 to 92% sensitivity, ma'am.
Is it better than people or it is less than people?
People's sensitivity is more than tau brush, ma'am.
So actually more studies have to be done to
for tau brush,
that which is more sensitive. So basically it is a small flexible brush which is around 26 centimeters in length, and the brush at the top is around 3 to 3.5 centimeters. So it is put inside the endometrial cavity and it is rotated 4 to 5 times, and it is going to collect the endometrium up till the depth of 1.5 to 2 millimeters. And after you remove this brush, you put it in a fixative, and then it is then evaluated by the pathologist. So this is very important. There can be inter-observer variation also. So pathologists have to be trained to be reading it from the fixed sample, right? So this is one of the things you should also know about.
So what was done in this case, in your case?
In this case, an office endometrial biopsy was done for the patient. And on histopathological examination, two possibilities were given to us for the case. That is endometrial hyperplasia with atypia and endometrial carcinoma, endometrioid type, FIGO stage 1, FIGO grade 1. And on further confirmation with our pathology department.
Just a minute. Go slow, bache. Go slow. We may need to ask you some questions. No? So, what is the possibility that both of these things may be coexisting?
Ma'am, with the endometrial hyperplasia with atypia, there is 25 to 43% chances of coexistent endometrial carcinoma. So the chances
both are the estrogen dependent conditions, and generally endometrial hyperplasia with atypia is a precursor for the endometrioid carcinoma. Okay,
but is 8 to 29% chances increase.
Yeah. That is a progression, but coexistent can be around 30 to 40%.
Yes,
it can be. Okay. So if it was only complex, and the complex, do you agree with this report? Complex endometrial hyperplasia with atypia. Do you follow this classification nowadays?
No, ma'am.
How do you classify hyperplasia?
According to WHO 2014, the endometrial hyperplasia is now just classified into two subtypes: endometrial hyperplasia with atypia and without atypia. These are the
now, suppose in this situation it was endometrial hyperplasia without atypia. How would you have managed this case?
Ma'am, if it was endometrial hyperplasia without atypia, then we could have offered continuous oral progesterone or LNG-IUS, which is a better choice.
You have preferred oral or LNG-IUS?
And followed by a biopsy every 6 months. Yes, ma'am?
what was your preferred route?
Ma'am, LNG IUS would have been a preferred
then you should
treatment
say
of
first,
choice.
no? If you are
Treatment of
sure,
choice.
then
Yes.
yeah. So treatment of choice, you always say first.
Yes.
Okay. Okay. Then how will you follow up?
Ma'am, we would like to perform a biopsy every 3 to 6 monthly for this patient. And if after 6 months, we have to have 2 negative biopsies to stop the screening protocol for the patient.
Okay. And now, if the report was with atypia and there was no endometrial carcinoma, then what was
then
your
we would
management?
have, if the family of the patient is complete, if the patient is
this patient, Bachi, we are talking of this patient.
I mean, this patient, then
we
would have offered a abdominal hysterectomy and bilateral salpingo-oophorectomy.
Okay. Okay. So what was the final report in this case when you reviewed it?
Ma'am, when we confirmed with the pathology department again, the final report that they gave us was endometrial carcinoma, endometrial type, FIGO grade 1.
FIGO grade 1. Okay. How FIGO grading is done? Can you tell us something about it?
Ma'am, the grade of the tumor is decided based on the solid growth pattern in the tumor. So if it is less than 5%, it is grade 1. If it is 6 to 50%, then it is grade 2. And if it is more than 50%, then it is grade 3. And grade 1 and 2 are found to have good prognosis, whereas grade 3 is found to be poor prognosis.
So grade 1 and 2 are considered low grade disease.
Low grade.
Okay. Good. So will you like to do any further investigation in this patient, or you will go for definitive management?
Ma'am, we can go in for further investigation for this patient. We can offer the patient a better imaging modality to see for the extent of the disease in the uterus, and to see for involvement of any cervical stroma or adnexae. So I would like to offer a contrast enhanced MRI for the pelvis in this case. We could also offer a CT scan, but I would like to choose a contrast enhanced MRI.
CT scan is not good for the seeing the involvement of the
myometrial invasion, and
tissue differentiation is not good in CT.
Yes,
right. So you can go for MRI pelvis if it is available. Okay. So why? How will it help you?
Ma'am, it helps because it allows us to see the myometrial invasion.
It appears to be a uterus confined disease, right?
Yes, ma'am.
So in any way you will be going for abdominal cystectomy, staging laparotomy.
Yes, ma'am.
Okay. Do you do clinical staging or
surgical staging is done for CA endometrium.
Okay. So CA endometrium is surgically staged.
Surgically staged.
Yes. So that is why we are talking why to do MRI when we are going to do surgical staging and it is a uterine confined disease. So we may as well go for directly surgery.
Ma'am, we can go in for a direct surgery, but because we have the modality of MRI available, we would like to see in the myometrial invasion, the cervical and parametrial involvement. Because if we find any cervical or parametrial involvement, then we will plan our lymph node sampling accordingly.
You are not suspecting parametrial involvement, Bache, when you have done the PBR exam.
Cervical stroma involvement. And myometrial invasion. Mainly cervical stroma involvement. And the depth of myometrial invasion in this.
Yes. So myometrial invasion, how will it help you in planning your surgery? That is what I am asking.
And because if there is more than 50% myometrial invasion or cervical stroma invasion, then she becomes a candidate for lymph node sampling as well.
Okay. So you plan your surgery or the radicality of the surgery based on your how much is the extent of the disease in the uterus, whether myometrial involvement is there or cervical stromal.
So if there is no
MRI is better than CT, than ultrasound, TVS. What do the studies say?
Ma'am, ultrasound is equally, ma'am, it is also very sensitive. Ma'am, for endometrial carcinoma, it is equally sensitive and specific, ma'am.
Depends on the person performing and the machine.
Yes, ma'am. Yes.
If we have such experienced ultrasonologists, it can be as good as MRI also. But
MRI, yes, ma'am.
More or less, MRI pelvis is to be done in stage 1 so that you know the myometrial invasion or the cervical. So, okay. So it was done in this case, MRI was done?
Yes, ma'am.
Okay.
So what was the report?
It was done, and the MRI report.
Come near to the microphone. Yeah.
Ma'am, in this, an MRI was abdomen and pelvis was done for the patient. The uterus was found to be anteparietal normal in size, an ill-defined round lesion of 1 into 1 into 0.8 centimeter, which was hypointense with heterogeneous post-contrast enhancement, was seen submucosally, extending into the endometrial cavity with less than 50% myometrial invasion. There was also poorly defined junctional zone. No extension of the lesion was seen into the cervix or the parametrium. The perirectal fat planes were also found intact. Bilateral ovaries were found atrophic. There was no lymphadenopathy and no abnormality was seen in the upper abdomen or the kidney, ureter, and bladder in this case.
Okay. So what were your further plan? What will you plan for this patient now?
Ma'am, for this patient, we would like to do a surgical staging, ma'am.
So how will you go about it?
Ma'am, the surgical staging can be done, ma'am. There are two methods. We can do minimally invasive surgery and we can also do
We will do surgical staging and
staging and ma'am, lymph node sampling is done.
Yes.
TH with total abdominal hysterectomy with bilateral salpingo-oophorectomy with
Ayush,
pelvic
yes.
lymphadenectomy plus minus paraud.
Yeah. Okay.
Yes.
So you will like to go for surgical staging with TH with BSO?
Yes, ma'am. With pelvic lymphadenectomy, ma'am.
You will like to do pelvic lymphadenectomy in this case?
Ma'am, we would like to, ma'am, the recommendations are that we
will discuss about lymphadenectomy after your main surgery. So, but how do you do practically do the surgical staging? So what are the points that you do?
Yes, ma'am. Ma'am, in the surgical staging, ma'am, the first thing that when we enter the peritoneal cavity, we have to take peritoneal cytology, ma'am.
So you go by the transabdominal route.
Yes, ma'am.
And what is the role of minimal invasive surgery, or you have to go by laparotomy? Can you go with minimal invasive?
Yes, ma'am. Minimally invasive surgeries can also be done, ma'am. The minimally invasive surgeries are better in the way that, ma'am, the hospital stay is reduced, the duration of the hospital stay is reduced, and the morbidity of the patient is reduced. Especially in patients which are obese, ma'am, the post-operative surgical site infection, the risk of venous thromboembolism is also reduced in laparoscopic or robotic. Minimally invasive surgeries, ma'am, basically.
What is the effect on the long-term survival? Because in cancers, we are not more concerned about the immediate post-op, okay? We are more concerned about the long-term survival.
Ma'am, there is no difference, ma'am. In minimally invasive also, ma'am, there is a risk of recurrence of around to 11%, and in laparotomy, there is risk of 10%, ma'am. So there is no difference between the two.
In uterine confined disease, you can go for the minimally invasive surgery. And it has been seen very well that it has same survival as compared to laparotomy with better immediate post-operative.
What care will you take when you are doing a minimally invasive surgery?
In obese women.
Ma'am, we have to...
patient is obese.
Okay, ma'am, we have to ensure that we are not morcellating or like manipulating the uterus that much, ma'am. So it can lead to dissemination, ma'am, and we don't have to do that. Ma'am, morcellation is not done. And
manipulation, though, in a minimally invasive surgery, there will be a little manipulation.
Manipulation.
Power morcellator is not used, ma'am. Morcellation should not be done, and it should be done for a normal size uterus.
Tumor spillage should be avoided. So endobag can be used.
Yes, ma'am.
While we are doing a minimally invasive surgery, or the uterus can be removed by other.
Small laparotomy incision can also be given, ma'am. Yes. Mini laparotomy.
Yes. Okay. So peritoneal cytology, will you go for peritoneal cytology?
Ma'am, it is recommended that we do peritoneal cytology because it is a prognostic factor, ma'am. It does not change the stage of the disease, but it is helpful in prognostication, ma'am. If there is positive peritoneal cytology, ma'am, there is a 29% risk of recurrence. So it is just a prognostic factor, ma'am. That's why we do it.
Okay. So describe the steps, Vacha.
Yes. After doing the peritoneal cytology, ma'am, we start with the clockwise palpation of all the organs. Ma'am, we start from the paracolic gutters. We go in a clockwise direction. After the paracolic gutters, we palpate the ascending colon. Then we go to the hepatic flexure, the inferior surface of the diaphragm, the transverse colon, clinic flexure, the descending colon. Then we go to the retroperitoneal region is palpated, the omentum is palpated, and the parauterine lymph nodes are also palpated.
You have talked about the palpation, that is fine. Next,
any suspicious area, ma'am, if we find any suspicious area, biopsies have to be taken from those areas.
Okay.
And ma'am, after this, ma'am, we do total abdominal hysterectomy with the bilateral
salpingo or extrafacial? You do
extrafacial, ma'am. In this patient, extrafacial total abdominal hysterectomy will be
What do you understand by that? Extrafacial?
Ma'am, we remove the uterus along with the cervix.
That you do in the total hysterectomy, no?
Yes, ma'am.
What is intrafacial and what is extrafacial?
Ma'am, the extent till which we do.
Okay. So basically, fascia around the cervix that you remove with the uterus.
Uterosacral ligaments, yes, ma'am.
Not the
We're not
ligament.
removing, ma'am, in extrafacial, we are not removing the uterosacral.
Fascia. It is the fascia. Okay. Like vesicocervical fascia is there, because if when you are doing the intrafacial, like you are doing in the benign condition, you send the fascia down with the bladder. If you have
Yes,
seen, we give a cut and we send the fascia down with the bladder. Okay.
Yes.
So in the extrafacial, we try to remove the fascia. Okay. So so as to attain the free surgical margins, right? That becomes a prognostic factor.
Yes,
Okay.
ma'am.
So will you go for omentectomy or not, if omentum is looking normal?
Omentectomy is done, ma'am, if either on surgical staging we are finding there is any suspicious lesion, or if there is grade 2, ma'am, the type 2 endometrioid carcinomas are there. Type, ma'am, not grade, type 2. Then serous papillary.
Specifically, yeah.
Yes, ma'am. Serous and papillary.
Serous carcinoma.
Serous carcinomas.
In the serous. Okay.
Yes, ma'am.
So you go for the omentectomy. Even in the clear cell nowadays, they say that if it is normal, there is no role of biopsy. So now tell us, suppose she was a younger premenopausal lady, will you have done bilateral salpingo-oophorectomy, or you could have avoided you could have changed?
Ma'am, we could have left the ovaries, but we have to explain and counsel the patient that she has to remain in close follow-up, and we have to tell her ma'am, that
so what are the, no, you have to rule out certain situations, then only you can leave the ovary.
Ma'am, we can leave only if there is myometrial invasion is less than 50%, there is no lymphovascular space invasion. And ma'am, if the tumor...
So Ayushi, yes, that you will know afterwards. So there should not be any familial cancers.
Familial cancers, yes, ma'am.
In those cases, you can leave the ovaries in premenopausal after proper counseling. Okay. So now you tell us, will you send the sample for frozen section? Because like we are so much concerned, it is less than 50% or more than 50% invasion. Then we have to decide whether to do lymphadenectomy or not. Will you like to send the uterus for the frozen section and see, or you see on the cut section?
Ma'am, we see on the cut section, ma'am. Routinely, it is not recommended to send it for frozen section, ma'am.
Why? Because earlier we used to send. Yes. Why it is not? Because they say that frozen section generally it may not correlate with the final histopathology. Okay, it has a limited histopathology is there. Other thing is that like the sample is interfered with, so in future when the proper histopathology is done, it can interfere with the assessment of the invasion in lymphovascular space. Okay, which is a very important prognostic factor for the future adjuvant therapy.
Yes.
Okay, so now you tell us, will you like to go for lymph node dissection in this case or not?
Yes, ma'am. Ma'am, in this, ma'am,
what mode you will like to go for?
Yes, ma'am. The NCCN and the ESMO and the SGU guidelines, ma'am, all of them recommend that if the setup has sentinel lymph node biopsy, we should go for sentinel lymph node biopsy. If it is not available, ma'am, then there are risk factors such as if the myometrial invasion is more than 50%, if it is type 2 endometrioid carcinoma, or if the tumor is more than 2 centimeters, then we do selective lymphadenectomy, ma'am.
Okay. So if facility is available, you like to go for sentinel lymph
node biopsy. Yes, ma'am. Sampling.
Because sentinel lymph node biopsy is as good as, it has been seen that it is as good as doing the systemic lymphadenectomy.
Yes, ma'am.
Okay. So how you do it? How do you do SLN?
Ma'am, for SLN, ma'am, we use the most commonly used dye is technetium 99, which is radio labeled. We can also use, ma'am, the indocyanine green, in which we have to use an infrared camera. Ma'am, the dye is injected using a 27 gauge needle. Ma'am, in the diagram as it is shown, it can be injected at all these 3 positions. The most common positions used are 3 and 9 o'clock. And ma'am, then we wait. Ma'am, we have to give the dye 15 minutes before starting the cervix.
It is injected in the cervix and cervix, not in the
yes.
Okay, so you have
cervix,
to
yes,
you have to understand this thing. Okay?
Yes, ma'am.
So you inject, you do the superficial, and then you go deep and you inject the dye.
Yes, ma'am. And ma'am, it is to be done 15 minutes before starting the hysterectomy, because it takes around 15 to 45 minutes for the dye to absorb in the lymph nodes, ma'am, in the lymphatic chain.
So if then what you do? You inject the dye, then you see
any
else which can be used. Like we are not having indocyanine green is the dye. It is recommended. Okay, it is most sensitive.
Yes,
but if it is
we
not
can also use methylene blue, ma'am. 1% with.
What can be used?
1% methylene blue can also be used, ma'am.
Okay, so color dyes can also be used.
Yes.
Like methylene blue can be used, and you can see by your eyes, naked eye. So what will you do if the lymph nodes are you detect this SLN, okay, or what will you do if you don't detect?
Ma'am, if the nodes are detected, we do the, ma'am, those lymph nodes are removed, ma'am, if it is detected, ma'am. And if, for example, if on one side it is detected and on the other side it is not detected, then we remove, ma'am. One-sided lymphadenectomy is done in that patient, ma'am. And ma'am, any suspicious, ma'am, even if the lymph node SLN is negative, if we are suspecting and on palpation, if we are finding any suspicious nodes, they have to be removed, ma'am.
Okay. So if your patient warrants lymphadenectomy and you go for the SLN, like if it is more than 50% invasion or grade 3 disease is there, then you go for the lymph node sampling. So if SLN is done, and if the on the hemipelvis, on the side of the pelvis where lymph nodes are not detected, okay, then you have to do the complete lymphadenectomy.
Yes, ma'am.
On that side. Okay.
Yes, ma'am.
But like in your case, if available, then you can go for SLN because it was a type
grade
1
stage
cancer
1.
and grade 1. Okay, so it is a low risk disease. Then you could have gone for sentinel lymph node, and if there was no lymph node, then you can maybe avoid the lymphadenectomy also. So what are the conditions in which you will like to, what will be the extent of lymphadenectomy if there are situations in which you go for the lymphadenectomy? Not SLN, you go for complete lymphadenectomy.
Yes, ma'am.
Then you do only pelvic, or you will go for the para-aortic also?
Ma'am, in low-grade tumors, ma'am, we can only do pelvic lymphadenectomy, in which, ma'am, there is no lymphovascular space invasion, or, ma'am, there is the tumor size is small, ma'am, it is less than 2 centimeters.
I just like to point out, you should not talk of lymphovascular invasion at this stage, because as of now we are not aware. So don't talk of the things which are not there as of now. So whenever you are reading, it is my suggestion to all the PGs. So whenever you are reading, please try to understand, correlate with the situation, clinical situation also. Okay, that you will get afterwards.
Yes, ma'am.
Right. Okay. So in the high risk tumors.
High risk. Yes, ma'am.
Okay, then you will go
type
for
2.
Yeah. Then you go. Nowadays we are no more using type 1 and type 2. Okay.
Yes, ma'am.
The non-endometrioid carcinomas or grade 3 carcinomas, you go for the pelvic and para-aortic lymphadenectomy, and up to the renal vessels actually it is recommended.
Yes.
Okay. So what was the final histopathology in this case?
And in this case, we performed a TH-BSO for the patient, and pelvic lymphadenectomy was done without para-aortic lymphadenectomy because we found certain suspicious nodes in the pelvic lymph.
Okay.
So in this endometrial carcinoma type 1, grade 1 was the final HP with less than 50% myometrial invasion. And the pelvic lymph nodes that were sampled were negative, and the uterine serosa involvement was not there, and cervical stroma involvement was also not there.
In final histopathology, it must have been given like endometrioid carcinoma, right?
Yes, endometrioid.
So you have mentioned type 1, no? You should have mentioned endometrioid carcinoma.
Yes.
Okay. So what is now the final stage?
So according to this, our final stage becomes stage 1A, and according to the TNM staging, it becomes T1A N0 M0, and she's grade 1 endometrial carcinoma.
Okay. So tell me, on the histopathology, what are the prognostic factors which tell us, is your case a good prognosis, has a good prognosis or a bad prognosis for the future recurrence or overall survival?
Ma'am, this is a case of good prognosis because first, the histological type of the cancer was an endometrioid cancer, which has good prognosis as compared to a non-endometrioid.
So you tell me what are all the prognostic factors, right?
Yes, ma'am. So when the histological type was endometrioid, the histological grade was 1, which was low grade tumor, and the myometrial invasion was less than 50% in this case. There was no lymphovascular space invasion.
That is why I'm asking you, because in the histopathology, you should have described these factors. You should have written, like I'm sure your histopathologist must have given the report like no LSVI, you know? On no LVSI, no lymphovascular space invasion. You should have written these things, that it should, you have to specifically look for these things, right? Okay. So these are the factors. So age, is this a good age? What about the age in this patient?
Ma'am, age, she has she's 62 years age, and a younger age group would have better prognosis. But
so more than 60 becomes a adverse factor.
Adverse.
Okay. So now, depending on these prognostic factors, can you risk stratify is there a way to risk stratify patients to consider for the adjuvant therapy?
Yes, ma'am. According to the ESMO, ESGO, and ESTRO 2015 consensus, she falls in the low risk group. She is stage 1 endometrioid carcinoma with low grade tumor with
So
no
you tell us how you stratify the risk.
Ma'am, there are 5 categories in the risk stratification: low, intermediate, high intermediate, then high, and advanced disease. So in the low group, we have stage.
How does it help you? How does it help you in further management?
Ma'am, it helps us because it helps in planning the further adjuvant therapy that can be given to the patient. And in low risk group, we do not require any adjuvant therapy. In the intermediate risk group, we can offer
the overall survival in low risk group, and what are the risk of recurrence?
Ma'am, in the low risk group, there is only there is 80 to 90% survival rate in 5 years, whereas in intermediate it becomes 60 to 70%, and in high or
in low risk it is very high. Survival is in
90%, up to 90%, ma'am, in 5 years.
More than 95-97% survival is there. Okay, that is why you don't give any
adjuvant
therapy. Okay. So is there any other way, like in this diagram only it is written on the right side, there is
molecular staging.
Just tell us what it is.
Ma'am, if our center offers molecular subtyping in histopathology, we would also like to go in for that, because there are certain types, like there is POL, which is polymerase epsilon mutated group. DNA polymerase epsilon mutated group. If that is present in our tumor, then it is a favorable. It gives a favorable outcome. If it is mismatch repair, or it is if it is mismatch repair good, it is also a better prognosis. But if 53 mutation is present in this, or HER2 mutation is present in this, which is copy number high group in the molecular subtyping, then it gives us a poorer prognosis of the. So even if it is a low stage tumor, it will be upgraded if there is the stage of the disease will be upgraded if there is a P53 mutation as compared to a POL or a MMR.
This classification is recommended, but as of now it is not being, I think, done.
Not being used.
Not readily available.
Yes, ma'am.
But it is to be encouraged. Okay, so yes, if you see at in this table, you can see that stage 2 is high intermediate group, but yes, if it is POL mute endometrial carcinoma, then it becomes low risk. There is no need of adjuvant therapy if there is no residual disease, right? Yes, and similarly, if stage 1A is there, but if it is P53 abnormal, it becomes intermediate.
Then it becomes upstage.
So I just like to mention, there was a case actually who had a endometrial cancer. It supposedly was low risk. She was managed with hysterectomy, but after 2 years, but she had a family history also, no genetic study. After 2 years, she presented with widespread metastasis, even including the brain metastasis. She presented with epilepsy, and then it was detected that brain metastasis. We lost that patient, and she was referred after brain metastasis was. Okay, so some patients can have adverse outcome. That is why now the type 1, type 2 is no longer as certifying, because there can be subset of type 1 patients also with the poor prognosis. But overall, this is the risk stratification. So in your case, what will be the situations in it is stage 1 endometrioid carcinoma, where you will go for the adjuvant therapy, and what are the different adjuvant therapies that you consider?
Ma'am, there are various modalities for adjuvant therapy. We can give radiation therapy, chemotherapy can be given, there is immunotherapy, and there is hormone therapy. Ma'am, in the radiation therapy can be given, ma'am, we can give vaginal brachytherapy, we can give EBRT, which is external beam radiotherapy. We can give, ma'am, the whole abdomen radiotherapy can also be given. Ma'am, then, ma'am, I have, ma'am, divided it into like where vaginal brachytherapy can be given.
So, okay. Yes. Okay, so you have to understand, as the prognosis keeps on, it becomes a higher risk for the prognostically.
Yes, ma'am.
Then your therapy advances. Okay, yes, so like if it is from low to it becomes intermediate risk, then you go for the brachytherapy. If there is further risk is there, okay, high intermediate, then you combine brachy with the
external beam radiotherapy.
So when do you give brachytherapy? Suppose yours was 1B with all those favorable points, then it becomes the low. It becomes
Low
your
risk.
intermediate.
Yes, ma'am.
Okay. So now you tell me.
Yes, ma'am. Ma'am, we give brachytherapy when the disease is confined to the uterus, and when there is.
When do you start after surgery? Suppose in this case it was 1B grade 1. Okay.
Ma'am, we started as soon as the vaginal cuff is healed, and it should not be beyond 12 weeks, ma'am. It is started within 12 weeks, and as soon as the vaginal cuff is healed.
Around 8 weeks when the
6 to 8 weeks. Yes, ma'am.
6 to 8 weeks. It should not go beyond
12 weeks.
Okay.
Yes,
so how much it is given?
Ma'am, there are various regimens, ma'am, but the most commonly in the standard regimen that is there is the, in which we use, ma'am, 21 Gyra is used, which is used up to the depth of 5 millimeters, and it is given in 3 fractions, ma'am.
Okay. Okay.
Ma'am, and we use, ma'am, previously cesium and radium was used, but now we use iridium, ma'am, for giving.
So you have mentioned LVSI negative.
Yes,
so can you tell us, because it is a very important risk factor. So LVSI positive, you say when it is substantial LVSI are there, or more than 5 areas of invasion are there.
Invasion are there, yes, ma'am.
If it is less, then it is known as, so you should have written either it is negative or it is focal. Okay. Okay. So, so in your case, you will not like to give any further therapy.
No, ma'am.
Would you like to do any genetic testing in this case?
Yes, ma'am.
It is a very good prognosis cancer. It is just type 1. It is like grade 1 endometrioid, well differentiated. Stage 1.
Yes, ma'am. Ma'am, it is recommended to do genetic workup of the patient, ma'am, for all cancers. If ma'am, the facility.
What workup we do? But for what?
Lynch syndrome, ma'am. We can screen the patient for Lynch syndrome, ma'am.
So you look for the whether mismatch repair.
Mismatch repair genes, yes, ma'am. MSH2, MSH6, MLH1, or PMS2, ma'am. These genes are.
Directly don't go for the genetic testing. You basically go for the IHC. Okay.
Yes, ma'am.
Then you look for whether MMR proteins are there or not. Okay.
Yes.
So if deficient or not deficient, then you do the further testing. Why you want to know? She is a very good prognosis patient. So why to go for? Patient will ask, why I should go for all this testing.
Ma'am, the patient will have risk for other cancers also, ma'am, such as colorectal cancer. There is a risk of 50-60%. There is a risk of ovarian cancer, ma'am. And
ovaries you have removed, bache?
Yes, ma'am.
Ovaries you have removed, hysterectomy you have done.
Yes,
so she still remains high risk for the colon cancer.
Colorectal
so what will you do about it? You will not remove the colon.
Ma'am, we will do annual colonoscopy for this patient, and we will keep the patient in follow-up.
Okay. What else? How will it help otherwise? So for the patient, she can be under surveillance for the colon cancer.
Yes, ma'am.
What else?
Ma'am, it will also help the family members, ma'am, to be screened, ma'am. Ma'am, we will do screening for the family members also.
If the patient is Lynch, she has Lynch syndrome, okay, then you will screen the family members for the Lynch syndrome. Now, suppose her sister is Lynch positive, the Lynch syndrome is there in the sister, then what will you advise?
Ma'am, we will keep the patient in close follow-up, and ma'am, the definitive management is TH with BSO. We have to do that to reduce the risk of cancer. But till her family is complete, we will keep her in close follow-up, annual examination, and ultrasound sonography.
When do you recommend TH BSO?
Ma'am,
at what age?
Ma'am, it is around 35 to 40 years, ma'am.
Yes, so it should be done less than 40 years, and there are different recommendations as per the which gene defect is there. Okay, but roughly around it should be done less than 40 years when the family is complete. So they are also any other advantage of knowing whether she is MMR deficient? Anything else? So one thing is like you have shown in your slide. So it helps in the prognostic classification.
Yes, ma'am.
Okay, so if you know it is MMRD is there or not. Okay, and then there are certain immune check inhibitors in advanced or recurrent disease that therapy option also opens up if it is MMRD.
Yes, ma'am.
Okay, so how will you now follow up this patient?
Ma'am, for the first 2 years, we'll follow up the patient 3 to 4 monthly, ma'am, and we will counsel the patient about the warning signs, ma'am. If there is any calf hemoptysis, weight loss, any further bleeding is there in the patient, ma'am, or ma'am, we'll examine her 3 to 4 monthly for the first 2 years.
Tell me all the symptoms that you will advise the patient to be watchful for. One thing is bleeding.
Yes,
bleeding from where?
Ma'am, bleeding from the vagina also, ma'am, for loco-regional recurrence, ma'am. There is a 20 to 30% risk of loco-regional recurrence even after surgery, ma'am.
Stage 1?
Ma'am, not in stage 1.
In your patient?
No, ma'am,
What
not
is
in
the
mine.
risk of having a recurrence in your patient?
Ma'am, in my patient, ma'am, it is very low, ma'am. The risk is very low. Around,
overall in stage 1, it is how much?
ma'am, around 2 to 3%.
Okay, so it will be less than 5%, maybe 2 to 3%, because overall in stage 1, it risk is around 10 to 15%. Okay, and most of the recurrence they occur in when do they occur?
Ma'am,
If it is non-endometrioid type, if the grade of the tumor is higher, that is grade 3, or if there is a significant
No. I said after surgery or after definitive treatment, when is the risk? When is the more risk of having a recurrence? Is it later or after 5 years, after 10 years, or when is the maximal risk?
Ma'am, 2
Okay,
to 3
how do you
years.
follow up? Okay, yeah. So most
2
of the
to 3
recurrences
years.
they occur
They
in
will
the
present with
initial 3
recurrence
years. So that is why your more aggressive follow-up is in initial 2 to 3
2 to
years,
3 years.
and up to 5 years you have to be more aggressive.
yes,
Okay,
ma'am.
so you will tell them for the warning signs, symptoms she has to come, and when she comes to your follow-up, you will ask for the symptoms, and then you do the examination. Bleeding from anywhere, even the per urethra also. If urinary or hematuria is there, you will look for the recurrence. Okay, and then you do the examination. Will you like to do any investigation during
Ma'am,
follow-up?
investigation will be done according to the symptom of the patient, ma'am.
Okay. Otherwise, no investigation or imaging is required for the routine follow-up of a case of endometrioid carcinoma. Okay.
Yes, ma'am.
But if it is an advanced stage, okay, then you do the follow-up with the imaging can be done.
Yes, ma'am.
Okay,
Yes,
like
ma'am.
CT chest abdomen.
CT chest abdomen can be done. Yes, ma'am.
You can do 3 to 6 months. Then for how long will you follow up?
Ma'am, in the first 2 years, we do it 3 to 4 monthly. Ma'am, then we do it every 6 monthly for the next 2 years, and then annually we follow up, ma'am.
Okay, so the follow-up has to continue.
Yes, ma'am.
Now, just one more question. Suppose this was a very young patient.
Yes, ma'am.
She just married and she had bleeding, and you detected endometrioid carcinoma grade 1. Okay. So she wanted fertility, to preserve the fertility. Could you have offered any fertility preservation? Could you have left the uterus behind in this case?
Yes, ma'am. Ma'am, we could have left the uterus behind if it was only a stage 1A cancer with grade 1 type of tumor with endometrioid type, and it is limited to the endometrium with no myometrial invasion. So we would like to
anything
offer
else? Anything? No, there are more criteria. Anything else? No family history.
No family history of no family history.
Should not be the genetic defect should not be there.
Yes,
in familial cancer, you will not leave the uterus.
You will not.
That will become a contraindication. And in stage 1A, but disease limited to the endometrium, no myometrial invasion. Okay, and you have to tell the patient that it is not the optimal treatment.
Yes, ma'am.
Yes.
Okay. And as soon as her family is complete,
so
we would
how
advise
you will manage that case now? How will you manage that?
We could offer the patient medroxyprogesterone acetate 600 mg daily, or we could offer her megestrol acetate 160 to 320 mg per day, and we could keep her up in follow-up for 3 to 6 monthly endometrial sampling. And ma'am, this has around 73 to 81% treatment rate.
So, you will keep her under 3 to 6 monthly follow-up for how long?
Ma'am, till her family is complete, and after that we will ask her.
Ayushi, do you want to answer it in a better way? You have to understand.
Yes, ma'am. Ma'am, we'll keep the patient in.
What will you like to see when you do the biopsy? After 3 to 4 months, you will do after 3 months you will do the biopsy.
Yes, ma'am.
So what will you like to see on biopsy?
Ma'am, whether the resolution has occurred, ma'am. Progesterone can also result in resolution, ma'am. If there is still
how long you wait for the resolution to occur?
Yes, ma'am. 12 months. Not more than 12 months. We do not.
6 months. Yeah, 3 months and 6 months. Okay. So by 6 months, if there is no resolution, then if it is still persisting or it has progressed, then what will you do?
Ma'am, then we will counsel the patient for surgical management, ma'am.
Okay. Then no more
role of conservative management, ma'am.
Yeah. Okay. And if like Aparajita is answering now, if it resolves then you encourage her to conceive as early as possible.
As early as possible.
Preferably going for the IVF.
Yes.
Okay, and as soon as family is complete, you have to go for, even though it has resolved, then still you have to go for the definitive surgery. Okay,
Yes,
so you be clear. So most important is that you have to wait for the resolution to occur within 3 to 6 months. You can't leave such patients. Okay.
yes.
So that's it. Now I think.
And any other thing which we can do in histopathology?
Ma'am, we can see the hormone receptor status, ma'am, the ERPR status.
So you need to mention that also. We have to look for the ERPR status also.
Generally, if it is stage 3, then it is recommended that you should do as per NCCN guidelines. Estrogen receptor status and MMRD.
So hormonal therapy can be.
Things, molecular studies. In those cases, IHC studies should be done. Okay. So can you just tell me where is the role of chemotherapy? This last question.
Yes, ma'am. Ma'am, chemotherapy is recommended, ma'am, in advanced stage cancers, ma'am. It is a role in stage 3 and ma'am stage 4. And
any type of cancer where it is recommended in early stage also?
And stage 1 is serious
non-endometrial type, ma'am. It is recommended that we give chemotherapy.
Okay. And any other advanced therapy available?
Ma'am, immunotherapy can also be given. Ma'am, it can be given, ma'am, even after in a recurrent disease, ma'am, immunotherapy can be given. Immune checkpoints are there, ma'am.
So there are many advancement in the therapy now.
Yes, ma'am.
Okay, I think we have completed our time.
Okay, Dr. Rashmi, and I will invite Dr. Rupinder Sekhon to say a few words.
Yes, ma'am.
Let her give her expert comments.
Yeah, yes, ma'am.
Good evening. Good evening, everyone. Can you hear me?
Yeah, yes, ma'am.
Okay. So absolutely excellent presentations, and I have to congratulate the moderators also that they brought out all the relevant points. Just a few more points. See, it's all very well to talk about advanced things, but there are a few simple things that we should always keep in mind. I might have missed out. Was a pap smear done for this patient?
Yes, ma'am.
What was the report of the pap smear?
And it was negative for any intraepithelial lesion or malignancy.
Okay, so that's very nice. Because we have to remember that if the pap smear shows us abnormal glandular cells, then this patient has a 4% more chance of a local recurrence. So you have to be careful that if the pap smear says August, whatever type of surgery you do, you must make sure that you take a vaginal cuff as well.
Yes.
Okay, that is important. Then two things. Yes. Then a few simple things that you need to remember is that any patient who has endometrial thickness of 4 mm or less than 4 mm with a single episode of postmenopausal bleeding, in her, the chances of endometrial carcinoma are again less than 4%. However, this increases to 10% if there are repeated episodes of postmenopausal bleeding. So when you're taking history, be very careful that to ask her how many episodes of postmenopausal bleeding she has actually had, not just discharge and not just maybe a feeling of wetness or foul smelling discharge or all that, but actual postmenopausal bleeding, how many episodes she has had. Okay, and when it comes to lymph node dissection, now things like I'm removing suspicious lymph nodes, I'm removing palpable lymph nodes. See, this is not the standard of care. We have to evaluate that what are the chances of a particular patient having lymph node positivity. Because we have to remember that if it is a grade 1 or 2 disease, the chances of pelvic lymph node positivity is about 3 to 4%. And para-aortic lymph node positivity is less than 4%. So if this patient is obese, it's a difficult surgery, you can easily omit doing any kind of lymphadenectomy. However, if it is a grade 3 disease, you can have a pelvic lymph node positivity up to 34% and a para-aortic lymph node positivity up to more than 14%. So if it is a grade 3 disease, you must do a systematic pelvic lymph node dissection, bilateral pelvic lymph node dissection, and a para-aortic lymph node dissection right till the renal veins. There is no excuse for not doing all this. Okay, please do not do just a lymph node sampling here and there. That has got no meaning at all. Okay, and also please do not do this, that palpable lymph nodes, this, that, and the other. That has got no meaning. When we talk in terms of removing palpable lymph nodes, so to say, or enlarged lymph nodes, macroscopically enlarged lymph nodes, the role of removing these kind of lymph nodes is only there in CAOV, where it is basically a debulking surgery. And lymph node dissection per se is not going to impact survival. Okay, so this is an important point that you need to remember. Then when we come to diagnosing endometrial cancer, PIPL, like you said very nicely, is PIPL or even a DNC for that matter. Accuracy can be almost up to 96 to 97%. However, if there is a polyp, you are going to miss that polyp. The chance of you missing a single of, missing a sample from a polyp can be as high as 50 to 85%. And one of the most important reasons why you will graduate to a hysteroscopy DNC from a PIPL is when the sample which you have obtained from a PIPL is insufficient. So if your pathologist comes back and tells you that the sample which you have sent, the endometrial sample which you have sent is insufficient, please go ahead and do a hysteroscopic DNC. Now, what is the advantage of a hysteroscopy DNC? Number one, you can actually visualize the whole of the endometrium under high magnification. And areas like your ostia, bilateral ostia and cornual regions, all those regions you can see very well. And if there is a single small lesion, you can biopsy that, so you do not miss that. But of course, I do agree that PIPL is very easy and can easily be done in your OPDs, and of course, it is more convenient. Then one of the students, they said that P53, before I say this, let me tell you something, that P53 is something which is very easily done, and your pathologist can do it even on the endometrial sample. And it is very important to do P53 because if P53 is positive, even if it is a grade 1 or a low grade carcinoma, there is still a chance of it being very, very aggressive. And because it is P53 positive, even if it is low grade, we need of cervical lymph dissection, paraortic lymph node dissection, mental biopsy, peritoneal sampling, and all that. So that is the importance of doing a P53. Also, we have to remember that if the tumor expresses P53 mutation, then this is the patient where we have to give chemotherapy. And if they're expressing MMR, then these are the patients where radiotherapy is more effective. No? These are a few bench rules that one should follow when you are looking after a patient of C endometrium. And I think apart from that, I think perhaps I've noted one or two more things. Can conservative management, okay. Now, when we come to fertility sparing, surgeries, or we come to management of low-grade carcinomas for patients who are nulliparous or where we want to preserve the fertility. One very important fact is that you have to counsel the patient that this is not the standard of care and that she is taking as much of a risk as you are also taking. Okay, be very, very careful because you might suddenly be faced with a litigation because nowhere in no guidelines do they say that this is the standard of care. And also you have to explain to the patient that you can do this conservative management only if there is a single lesion. It is less than 2 centimeters. There is no myometrial invasion, and that when you do an MRI of the pelvis, you find that the endomyometrial junction is completely preserved. So only in such patients can you do this kind of management. And it is mandatory that you follow it up every 3 months with a MRI of the pelvis, wherein what does the MRI of the pelvis define? What is the information it tells you? 3 very important things. Number 1, the endometrial lesion, the size of the lesion. Number 2, any myometrial invasion. Number 3, the lymph node status. So it is for these three things that we actually do a MRI pelvis in cases of where we suspect a C endometrium. Okay, so to get back to my point, it is very important to explain to the patient that she will have to undergo an MRI as well as a hysteroscopic DNC every 3 months. And once you get a negative report, you have to follow that up with 3 negative reports. And only then can you completely stop giving her progestins and tell her to go ahead with trying to get pregnant. And like the moderate very nicely she put it, she will definitely require assisted reproductive technique help. I think that's all I really want to say. If there's any other way in which I can contribute, I would be happy to. Thank you so much for the opportunity, Dr. Sunita and everybody else.
Thank you, Dr. Rupinder. It was very nice and very well explained. In fact, most of the things were covered by Dr. Rashmi and Dr. Neha. But still, these practical tips which you told that had to be done. Yeah. So any query, Bachcho, Ayushi and Aparajita, do you want to know from the expert?
Yes, ma'am.
She is available if like you have read the subject, which you couldn't understand, you wanted to know further, you can ask Dr. Sekhon.
Ma'am, the role of just frozen section, ma'am, because we could not.
So we no longer do frozen section for anything at all, because what they say is that visual inspection of the endometrium, wherein we are actually looking for, see, why are we doing frozen section? Just to look for myometrial invasion, isn't it? Now there is adequate concordance of visual inspection as well as frozen section to rule out myometrial invasion. So we do not really go in for frozen section. That is one thing. Secondly, so I don't know how it is done in your hospital, but by and large in cancer centers, the pathologists, they get very cross if you give them a specimen which has been cut open vertically, because they do their sections horizontally. So we no longer do all this, and MRI gives you pretty good information as far as myometrial invasion is concerned.
Thank you. Thank you.
So because that is going to determine whether you're going to do lymph node dissection, isn't it? That is what the frozen section is all about. And as far as whether it is low grade or high grade carcinoma, or what is the further dispensation, the current molecular classification gives you a very good idea. So that is what you do. And that pole E, which I think one of you mentioned, is not really getting done. We have done a few cases, maybe about 30, 35, and we got only one pole E positive. So, and it is pretty expensive. I think it's going to take some time before pole E becomes the standard of care in our institutions as well.
Yeah, it's not available even in many institutions abroad also. So,
yes, quite right.
So I think we have no questions in the chat box also today. So everyone is fully satisfied with our class. And on behalf of AOGD and the Delhi PG Forum, I would really like to thank our chairpersons, Dr. Ashok and Dr. Rupinder. Dr. Rupinder has really given valuable inputs regarding P53, role of MRI, and about lymph node dissection and so many other things. And we also like to thank our moderators, Dr. Rashmi and Dr. Neha, who have really toiled hard with our postgraduates to bring this class up to the mark today. And of course, our postgraduates, Dr. Ayushi and Aparajita, have really done well. And lastly, I would like to thank Dr. Deepika for giving us this lovely platform. And last but not the least, our audience. Thank you so much. You are fully satisfied. You have no questions. So that is really good.
It can be other way around also.
Maybe. We should think positive. So
yeah, absolutely. I agree. Let's be positive. Yes.
So thank you so much. And
thank you, ma'am. Thank you, Sunita, ma'am.
Okay, thank you so much,
Shivani, ma'am, for this opportunity. And I would like to thank Dr. Rashmi too. She has really guided the PGs.
Enjoyed actually.
Yes, and we really enjoyed.
interacting with them.
Yeah, it was a wonderful class.
Yes,
It was a good
it was
experience.
really nice.
Thank you,
Very
ma'am.
So,
Okay,
ma'am, we take this opportunity and thank everybody from Jagsonpal. Jagsonpal brings to you LycoRed, the cell protector, which has anti-oncogenic properties. Also, LycoRed Prex sachet, which is L-arginine, lycopene, and DHA for high-risk pregnancies. Maintane injection 250 and 500 mg hydroxyprogesterone caproate for preterm delivery. And the latest brand that we have is dydrogesterone, micronized dydrogesterone as DIVATRONE 10 mg tablets. So look forward to your support to the Jagsonpal products, and thank you all so very much.